I'm going to talk about measuring quality of end-of-life care. So I'm the Warm-Up Act, or the Support Act, I don't know. So I hope you'll enjoy all of the afternoon and not just the main act. But anyway, just a bit of background. I've presented this slide before. We did this 2 years ago, and I haven't even updated it because even though that goes to 2013, proportionately haven't changed. But just to get an idea so that you know, just over 1,000 adults a year die in Tower Hamlets, probably more like 1,100 to 1,200 in your registered population, because as we know, our registered population is slightly different. And we have a young population profile, so not surprisingly, we have more deaths in younger people. Age standardised rates are no longer higher, but they used to be. But it's important when we think about the patients that we're looking after, that 33% of all males that die are under 65 and 20% of them are under 55. So we don't have as many of the frail elderly, less than 30%, whereas nationally it's probably more than 40% now. Underlying causes of death are very similar to national: cancer, CVD, respiratory, most for other. But just, I don't have to tell you this, more other causes, so morbidity recorded on death certification, particularly respiratory disease at all ages. So we know the population we're looking at, and it's reflected in their death. This is the national strategy, and we're pleased to say, I mean, it's been around since 2015. It is not targets for end-of-life care, it's about ambitions and working towards. And it's very focused on individualisation, personalisation, quality, around quality and equality. I'm pleased to say every person gets fair access, comfort and well-being, which includes pain relief, coordination, integration, trained, knowledgeable staff who use their knowledge, and communities that are prepared to help. So not just us looking after people, but whole communities understanding it. So really quickly, what can we measure? That's what I'm talking about with the data. So these are the things I've picked out from the ambitions that would reflect that individualisation. So early identification and personalised care, not surprisingly, looking at people that primary care has identified as needing palliative and end-of-life care, because this gives an opportunity in an ideal world, and we hope that's what's happening, for planning, for discussion, for those conversations with patients and their families, and for people's preferences to be met. Now, place of death has been used as a bit of a whipping stick, actually, because I'll explain a bit more in a minute when I show it to you why there's a rationale for that, but basically it can be measured. And so there's an assumption that that would help us to identify that people are getting what they wanted and their preference for end-of-life care. This is a new indicator, likely, I understand, likely to become an important indicator, is the percentage of deaths with 3 or more admissions in the last 3 months, because it could well be a reflection of unplanned care and lack of integration. And then for some years, we've been looking nationally at survey responses, and we've tried to do this locally as well, of bereaved people. And finally, just locally, we've done a health equity audit of specialist palliative care from St Joseph's Hospice, and I'll explain that if I've got time to get to it. Is anyone going to ring a bell for this? Right. Okay. So just quickly now, why do we what's the reason for that? So I mentioned identifying on your palliative care register, that's a QOF indicator, but it also suggests that people are getting personalised care with their preferences met, and there's integration. So the Higginson model predicts 75% of all deaths could be anticipated or expected. Don't worry about that slide, but for Tower Hamlets it suggests 750, moving up to near, 780 or something by 2022. That's all cancer deaths and about 2/3 of other deaths, and that's the model. So, what happened when I asked CEG how many people who died were on palliative care registers? It appears to be less than half of the people who died. So, does that model overestimate what you should anticipate in a young population? So, anecdotally, GPs talk about rather unexpected deaths in relatively younger people who've got perhaps multiple comorbidity, but death wasn't quite predicted. are we under-recording? So when we looked at the health equity audit for St Joseph's, we saw well over 500 people, 525 people, for example, were using St Joe's Hospice who were Tower Hamlets residents, which was way more than the number of people on palliative care registers. So perhaps it's just not being recorded. We shouldn't look at single-year data. And I won't mention this is a geeky thing, but if you look at the slides, PHE actually have a conceptual model which suggests that we had more like 50%, but I'm not going to go into it with geeky. Okay. Right, the place of death. So this is the whipping stick. Because most people, when asked, not during their end-of-life care, say they would prefer to die at home, there's an assumption that end-of-life care in hospital is going to be of worse quality. And actually, national survey responses of bereaved carers has tended to indicate lower satisfaction, although there's been some changes. So that's important. Now, 55% of all our deaths occur in hospital. Actually, that's 2017-18, so it's rolling data, which is better than 60% from a couple of years before, and very similar to London and more than England. Importantly, deaths at home the same, more deaths in hospice. It's our care home deaths that make the difference. We have a small number of only 2 nursing homes, and nationally, 22%. We're moving towards a quarter of deaths in care homes. We don't have anything like that. We don't have the frail elderly, and we don't have the nursing home places. But just importantly, in England, overall, a third of care home deaths are temporary residents. So they are people likely to have been discharged from hospital for end-of-life care in care homes. So I think it's quite important when we take those big numbers. And there is recognition. So I think there's going to be less focus on that, and hopefully perhaps more focus on this. So the only data I've got here is from 2015, which suggests that moving towards 10% of people who died had 3 or more admissions in the last 3 months of life. Doesn't sound great compared to England, but the data is a couple of years old, but it's important to recognise, but hopefully we may see some change. I don't know how I'm doing for time, but I'm just going to move a little bit on to the sort of reflections and quality back. So the National Voices survey, for 4 months every year, or asks people, bereaved people who are registered deaths, about the experience of their loved one dying. And it's a very big survey, but there are big responses, but not big enough by CCG to be able to give you local data. So I've picked out a couple of questions here, and this is the most recent survey in 2015. The patient was treated with dignity and respect in the last 3 months of their life. Hospital doctors and nurses come lowest. Still more than 50%, but not as good, for example, as hospices and community nurses. GPs, 70%. There's always a little worry, isn't there, at the end, that, sort of 14-15% of people found that there was hardly any or never any dignity and respect through their GP. And I'm flagging it up because it's national. But one thing to remember, and I'll mention it again, is when this was cut by deprivation, people in the most deprived groups have poorer satisfaction overall. So we may well be on the lower end. But it's not local. We have tried twice to do local surveys with good qualitative feedback, but insufficient numbers to be able to present anything. Catherine is talking to me about another bereavement survey that the CCG are hoping to do with a simpler questionnaire rather than this massive Voices one. And we're looking at Bart's Health Bereavement Surveys, which may also give us better data. Relief of pain around thinking about comfort in the last 3 months of life. This one is a little worrying, that less than 20% of people who died at home felt that pain was relieved all of the time, and actually a very high proportion, more than 50%, partially or not at all. So I flag that up again because it's something that perhaps could be avoided. Care homes, a bit better. Hospice, not surprisingly good. And overall quality in the last 3 months of life, again, a bit surprising that actually only a third of people named the GP as providing excellent care during the last 3 months of life, and not surprisingly, hospice care. I shouldn't keep saying not surprisingly, but nationally that happens, and we kind of expect that to happen because it's a very specialised area and people aren't doing other things as well. Everybody else is doing a lot of other things. But as I said, significantly more people in the most deprived groups had reported poorer experience, and we should remember that. So the last thing, and I'm sure I'm over time now, is talking about health equity. So there is evidence nationally of inequalities in access by particular groups of people. So vulnerable groups that often don't have good access to services anyway, homeless people, drug and alcohol, substance misuse, sex workers, people in prison, but also people with dementia and BME populations, black and minority ethnic groups, appear not to get the same access to high quality end-of-life care. So we looked at that locally, and we looked at specialist palliative care for St Joe's. Not everyone needs that, but we felt if that was equally used and there was fair access, it was a good indication that there was fair access overall. So just quickly, these are deaths on this side, and this is service use. So greater increase in service use between 2010-2015. We haven't gone on from there, although the number of deaths pretty similar. So I'm just going to show two things, one on ethnicity and one on cause of death, I think. So interestingly, this all started because St Joe's wanted to do a bit more outreach, didn't feel they were reaching all the cultural and ethnic groups in the population. So when we looked at place of birth, because death certification doesn't have ethnicity on it, there was almost identical use by people who were born in Bangladesh and died, and people were Bangladeshi using St Joe's. And numbers were quite high. And probably the only one that was slightly different was UK and Ireland and England born. And possibly what's happening there is some people, second and third generation born in this country, picked up as UK and Ireland born, but in fact with a different ethnicity on St Joe's. We're not sure. But we certainly appear to be meeting the needs of people by ethnicity. And then the other thing we looked at here was main underlying cause. Actually, there might be another slide, we'll see. And not as nationally, more people with cancer use hospice services. And low service use, although some, respiratory disease and circulatory disease, only 8%, although combined, these are 40% of all deaths. I think this might be picked up later, particularly talking about identifying palliative care needs, because trajectories are much less obvious. Patients might be younger, and so for all sorts of reasons there may not be referral, or people may refuse because they don't see themselves, they're not ready to see themselves as end of life. And dementia, we didn't pick up many people with dementia. It could have been a recording issue. It may be that the needs are being met by care homes and by community support by local teams. And at that time, there was no routine recording by St Joe's of any groups that we know get poorer access. So one of the things to come out of that equity audit, I hope, and I'm looking at Matt and James, is actually to start recording this, because it doesn't mean it wasn't happening, but we're not recording it. And when we are looking at quality, it's something we should be thinking about. I think that is the